The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. Thank you so much for joining our webinar today. This is Tyra London. I'm the Director of Marketing and Project Development for American Nurse Today. I just have a few housekeeping things to go into before I introduce our moderator, Lily Jelinas. Today's webinar will last approximately 1 hour. We will feature a live Q&A session at the end of our panelist presentations. If you'd like to ask a question, you'll see the GoToWebinar dashboard, which appears on the right-hand side of your computer screen. If you are unable to view the full dashboard, please click on the orange arrow in the upper right-hand corner to expand your dashboard. The audience will be muted during the webinar. Please use your dashboard to communicate any issues you may run into and to submit your questions. We will tell you that our audience will be receiving an email within 48 hours that will contain a recording of the webinar, and please feel free to share that with your colleagues. Also, the webinar will be available on demand at americannursetoday.com for 6 months. I'd like to introduce you now to the moderator of our meeting today, Lily Jelinas, who is System Vice President and Chief Nursing Officer at Christus Health, and is also, we're thrilled to death, Editor-in-Chief of American Nurse Today. Welcome, Lily.
Thank you, Tyra, and hello, everyone. Thank you for joining us. We're excited to welcome you to this session on such an important topic. Our plan for today is to review key research results related to acuity-based staffing, explain how to make the business case for acuity-based staffing, and share a case study of acuity-based staffing through the experiences of a large integrated healthcare system in Ohio. We'll also discuss next steps, understanding where to go from here. Healthcare organizations today are implementing several strategies to enhance clinical and financial outcomes. Rapid is our new normal, so how do we know what changes will speed the improvement to better outcomes, especially at the bedside? Acuity-based staffing is one of the changes getting heightened attention and in some states, as you'll hear, legislative attention. Acuity systems maximize patient as well as nursing outcomes through enhanced decision-making, improved operational outcomes, improved nurse and patient satisfaction, all while improving financial performance through lower cost. On your screen, you'll see the list of our esteemed panel of experts. So let's begin today's discussion with John Welton, who is Professor and Senior Scientist for Health Systems Research at the University of Colorado College of Nursing. Dr. Welton, welcome to the program.
Lee, thanks, and good morning and good afternoon to everyone. If we go to our first slide here, we're going to look at evidence-based staffing today. But I'm going to commit an act of heresy here and say that we really need to think beyond just staffing alone and really begin to look at things like the actual nurse-patient assignment, how efficient, effective we are, productive. What are some of the characteristics that drive good outcomes, and also the cost of nursing care, and ultimately we'll talk about nursing value. So let's get started and kind of see where we are. I think we all know that, and for those of us who have enough experience, and I'll use that word lightly here, in nursing, we know that things have changed over the past couple decades. Patients are sicker in the acute care setting, and they're getting in and out of hospitals quicker. So that affects the overall, not only staffing, but the actual intensity of each patient receiving nursing care. Next slide, please. There's a clear relationship between staffing levels or ratios and the overall cost of that care. So we know that, for example, at a ratio of 1 to 4, on average in a 12-hour shift, a nurse is giving approximately 3 hours of his or her time. But based on wage, that the amount of that, the cost of that care can vary depending upon both the wage and the time. We can see on the left, those would be acute care ICU patients, but even on the right, when we go ahead and look at, say, ratios of 1 to 6, 7, or 8, there's still a cost related to that. And what that does is tells us that there's an important consideration here with staffing levels, is that it affects the overall cost of nursing care that's delivered to the patient. Next slide, please. Just a couple studies that I've done. The one on the left was at a single academic medical center, and this is just the med-surg units. We can see it. Here's a classic normal distribution as far as the overall hours of care. What we see is that any patient could receive anywhere between 5 and 15 hours of care, and this is including some of the intermediate care units. So in an academic setting, they tend to look like ICU patients in a community hospital. So there's a lot of variability in the overall care, the time that nurses spend, and the cost of that care depending upon the patient's needs. On the right was a study. We looked at Massachusetts hospitals. I can't remember how many there were, 194. And again, we see that same amount of variability within the patient care population and the settings in which care is delivered in acute care hospitals. Next slide. So that really begs the question, if we look at nursing as a staffing ratio or hours per patient day, or if we look at the midnight census, what that does over a period of time is looks at nursing as basically as a constant. And I'm hearing someone with the phone here. And it begs the question, what's an average patient? I think all the nurses are on the webinar today. We kind of scratch our head that there's no such thing as an average patient to us. I mean, patients have different care needs. Even the same patient on different days of stay has a different need for nursing care. So that the way we organize, the way we measure nursing care in the current environment, and traditionally this goes back to the 1930s, is kind of a barrier to us as far as really beginning to understand that relationship between nurses and patients. Next slide, please. We can see differences in the severity of illness. This is the all-payer refined DRG, and we actually were collecting, the nurses were actually writing their actual times. So these are actual time values, not the average values. And we can see that there are differences. Sometimes the differences are quite large between a patient with a severity level of 1 to 4. And in other cases, there's really not much difference between the two, between the different severity levels. So what that tells us is that the medical care and the way we actually reimburse care based on a diagnosis or a procedure is somewhat different than the nursing care, and we don't actually account for the differences in nursing care in our current payment systems. Next slide. This is a study we did with some colleagues at Catholic Health Initiative a few years ago, and it's a pilot. We used a system where the assignment was known. We can actually calculate the actual direct care hours and the cost of those hours for each individual patient. This was 5 hospitals and I think about 50,000 patients. I can't remember how many nurses were involved in this study. And what we see is that patients that stayed 1 day had much higher average or mean hours per care on the floors, on the routine care or the med-surg floors than patients that stayed day 2, day 3, or day 4. We can see that after the 3rd day of care, that older patients, 65 and older, our Medicare population, required between a half hour and 3/4 of an hour more care per day. On the extreme right of that graph, we can see that patients that stayed more than 3 weeks on average required more care. And what was interesting, when we looked at that population, it was about 20% of all the patients in this series. They consumed half, 50.4% of all the available nursing care hours in dollars. Last thing I'll point out is that horizontal line is a proxy measure. That was the mean hours for the entire series of patients. That's a proxy measure for nursing hours per patient day. So we can see that, at least from a staffing standpoint, the current tools, the measures that we're using really don't represent the reality of the differences in the care needs of patients that we're serving. Next slide. This is another study, and this approach that Dr. Sharon Pappas, she's the Vice President for Nursing here in Colorado, it's for Centura. They looked at just a single unit, and they looked at risk and outcomes, which was quite interesting. This was a transplant unit, and they did a group process, and they came up with 4 indicators. And what they did was whenever the patient had one of these indicators, for example, they were a transplant patient or had hepatic failure, that they would adjust the actual assignment so that particular patient received a higher amount of time or nursing intensity. The slide on the right is representation as far as some of the outcomes: pressure ulcers, falls, urinary tract infections, and central and bloodstream infections. We can see that after the intervention, as far as changing the assignment, we can see a decrease in the number of these particular quality measures. Next slide. So that raises the question about the value of nursing care. And value, if we look at it from a classic business standpoint, it's represented as the relationship between quality and price. Some of the newer thinking, actually this is some of Sharon Pappas' work as well, that from a nursing standpoint, we need to begin to think about the outcomes and price as the resources that we're expending, and what do we accomplish as far as the team and each individual nurse. Next slide. It's been my honor to work with a group of extremely talented nurses and non-nurses across the country, and this work comes out of the big data in nursing and nursing knowledge development work out of University of Minnesota, and Connie Delaney, Dean up there, and Dr. Bonnie Westra have led that effort for the last 4 years. For the last 2 years, we've had an effort to a work group. Go back to the slide. Yeah, stay there for a second. We've had a concerted effort to go ahead and begin to look at how to measure nursing care value. In the first year, 2014, we began to realize that in order to measure nurse care value, we had to measure the value of each nurse providing care to the patient. As you see on the left, it's sort of a beginning framework for looking at nursing care value at the individual nurse who's a provider of care, and then begin to look at nursing care as that encounter between a nurse and a patient. Within the systems, electronic health systems, what we're doing is we're setting up models so that we can extract data at that individual, the individual nurse caring for each patient, and from those data begin to look and measure cost, quality, performance, and so forth, and integrate those data from both a clinical and an operational standpoint. And ultimately, we intend to develop new business intelligence tools, analysis, real-time performance metrics. Next slide. This is just, I'm only briefly just going to put this as a placeholder for right now. This is the model that we just published in Nursing Economics, and this is, we're moving ahead to test this. Actually, the Catholic Health Initiative data that I showed you a few slides before was one of the early tests of this, helped drive this model. But again, what we're doing is trying to use the existing data, not burden nurses to go ahead and collect new data to begin to analyze that relationship between an individual nurse and a patient within a certain setting. Next slide. Go ahead and give me the next slide if you could. Okay. Can we have the next slide, please? If one of the staff on, just make sure I'm still connected.
Yes, John, you're connected.
John, you're connected.
Okay, go ahead and give me the next slide, please.
The slide isn't moving. Can you just continue, and I will try to move the slide.
Right, I'll do that. Okay, yeah, no problem. From that information that we collect from the electronic health record, we can develop new ways to measure nursing care, nursing care cost. And what's interesting is we can look at it from the individual patient. For example, we can actually measure all and identify all the nurses caring for a particular patient. Or we can look at a particular nurse and look at all the patients that nurse cared for, or within this particular context, say the unit, the hospital as a whole. And from those data, it gives us the ability to go ahead and provide information either at that level or begin to benchmark across different care settings. From those data, we begin to get a better understanding as far as the variability of nursing care, staffing levels, assignments, and things like that, patient care outcomes as a complete whole, as far as instead of looking at each individual one. And this hopefully will give us some new information as we move forward in utilizing these big data things that we have, these big data processes and big data science as we move forward. Just one last note as far as how we we can look at nurse staffing. And one of the real problems of this has been, how do we come up with a gold standard? How do we measure nursing care, for example? What is the demand for a particular patient and the care that they need? And it's been hard because we've been struggling with this question for decades and really haven't come up with an answer. And last year we began to think about that and said, well, maybe instead of looking at the needs of the patients, we can look at the output or the outcomes of that care. And we began to think about different ways that we can look at it from a real-time standpoint. The quality metrics that we have now, as we noted before, they tend to be months, if not quarters old, so it's difficult to act on that within the current time frame. So we began to look at medication administration as sort of an exemplar of some of the new approaches as far as how effective we are in staffing. And the question we asked was, does nursing workload affect the ability to give medications on time? We're looking for delays and omissions, and also looking at patterns for PRN meds, especially opioids. And although I can't report any specific things, we're just beginning our analysis. What's fascinating is it's really telling us a lot about the overall care environment in a real-time environment, and we believe that that will help us begin to identify new metrics. For example, if you have a standard for giving antibiotics with plus or minus 30 minutes, if we begin to reach that limit, then there may be things within the environment itself. The patients are much more sicker. There's more patients. You have staffing shortages. We begin to look and measure at the differences in the time between it was due and administered as a way to help us understand how well the nurses are performing within that particular environment. Other things that might be possible, we can look at pain management, pain assessment, glycemic control, ambulation, and so forth. So these are new, what we believe are new markers for real-time quality metrics in relationship to some of the staffing, the workload issues, the workforce issues that that we're addressing here in this this particular setting. So last slide, just a quick summary, I'll just go ahead and introduce our next speaker here, and make sure I don't take too much of Dr. Needleman's time. So Dr. Needleman, Jack Needleman at UCLA, why don't you go ahead and take it from here.
Great. Thank you, John. Terrific presentation. Next slide, please. What I'm talking about is how do we create a model for acuity-based presentation. I'll talk a little bit about the business case at the end. I'm going to start with a topic John has already covered extensively, why we should be thinking about acuity-based staffing systems, and then look into the factors needed to do it, some criteria for assessing them, and thinking about commercial versus homegrown systems and what locally developed systems might look like. And then I'll finish up with some comments on the business case. So let's come back to this question of why do acuity-based staffing. Next slide, please. And the first answer to that is simply state legislation is increasingly requiring it. Many people on the call will be familiar with the California minimum staffing requirements. I would note that that legislation says minimum, and if the patients need higher levels of staffing, the hospital is supposed to know that and staff up accordingly in that system. That's one model. Other states are adopting models of requiring staffing committees to develop a local staffing plan, and some states are then requiring people to report on how their staffing is against their planning. There's continued pressure to expand these. The American Nurses Association actually has enforced the legislation for staffing committees with the executives and frontline staff jointly involved in designing the staffing models. And those staffing models need to reflect the needs of the patients. And the efforts to report on this are efforts to demonstrate the adequacy of staffing to the public, to the staff, to the government. And I would simply note in this regard that nurses have to start thinking about nursing care and presenting it to hospital administration, to patients, as the core service of the hospital, with expectations that it can be delivered reliably and keep patients safe. And that gets to the second reason for doing acuity. Next slide, please. Which is that we simply have extensive evidence that staffing is associated with efficient care and patient safety and reliability, the reliability with which care is delivered. This slide shows data from a 2007 meta-analysis of staffing studies through that time. The list has been expanded. The results are very similar, which basically show that mortality, infections, other kinds of outcomes are increasingly go up when staffing is low. But I want to call attention to the boxed item at the bottom, relative change in length of stay, which shows that when staffing is low, length of stay goes up. That's not just a safety issue, that's also an efficiency issue. Similarly, there are some other studies that have come out, and more that I know that are in the pipeline, that are going to show that the similar relationship between low staffing and increased readmission rates. And both of those represent, to me, the ability of nurses to get their work done and get it done effectively in ways that enable the patient to be moved efficiently through the care process. Next slide, please. Because many of these studies have been cross-sectional, they compare low-staffed hospitals to high-staffed hospitals, and people keep saying maybe it's something else about these low-staffed hospitals that affect it. Maybe it's the technology, maybe it's the doctors, maybe it's the quality of the nurses that are hired. There's a need for some studies which demonstrate the causality of this going beyond the association between low staffing across different hospitals and high staffing across different hospitals. This study is about as close as we're going to get. Nobody's going to randomize the staffing, but some colleagues and I had an opportunity at a large academic medical center which had a nursing acuity system that they used to identify the number of hours they needed per shift to look at what happened, and they also kept data on what the actual staffing was. We could identify shifts that were 8 hours or more below the target, essentially one nurse short on a shift. And we could identify which patients were exposed to those shifts. And what we found was, as the number of shifts that patients were exposed to, next slide please, number of shifts that the patients were exposed to that were below those targets by 8 or more hours, mortality went up. And it went up substantially. We also realized that their staffing system did not take into account unusually high turnover, so we looked separately at turnover and found that where turnover was high, and the staffing had not been adjusted for it, the mortality rates also went up. Both of these reflect increased workload demands on nurses. So this is about as close as we're going to get to a causal study, and I think it is, when folks say, well, is it really the nursing, this is the study at the moment, to pull out and wave. And I suspect more are coming down the line, but this is, at the moment, the gold standard for demonstrating causality between staffing and outcomes, particularly focused on the mortality outcome. Next slide, please. So if we've established the case for the why, then the question is the how. And what do systems that appropriately staff need to take into account? John talked a great deal about some of the patient elements of that, and some about the nursing components. This slide, which is drawn from an article in 2010, identified the factors influencing right staffing and put them into 3 broad buckets. One is the patient bucket. How complex is the patient? How dependent are they on the nursing staff for activities of daily living and other kinds of things? What kinds of needs do they have, separate and apart from their complexity? So there's a long list of patient characteristics. What this list also underscores is the role of who's on the nursing staff and what kind of experience do they have and what kind of training do they have. Certification is not here, but I would add that as well. What kind of skills, the special training and skills are they bringing to the care, and have they been matched with patients that need that? So the nursing staff itself represents a variable to consider in identifying how much staffing we need today on this shift. And then the third bucket is the unit and the organization, which has to do with the way in which care is organized, what kinds of expectations the system imposes on nurses for documentation, what's the physical layout of the floor, what kinds of support staff services do they have. If you've got, for example, supplies in the patient rooms, who's stocking the rooms? Is it the folks from Central Supply who come up and stock the rooms, or is it the nurses who are picking them up from a central location? Each of those are going to change the staffing, the demands on nurses, and therefore the staffing expectations. Next slide, please. Acuity is clearly central to many of these. Patient acuity is clearly central to many of these factors, getting the staffing right. So it's useful to step back and think a little bit more about some of the range of things that need to be taken into account about patients, not just acuity in terms of their disease or their status, but also things like how many medications are they getting, what kinds of procedures do the patients need to get in the room, what kind of patient education is needed, and what's the literacy level of the patient, how much time is going to be spent need to be spent to help a patient understand their condition, their post-discharge needs for care, and so forth. Psychosocial elements, and then the role of complicated medications beyond the simple counts of medications are all factors that Harper in this 2007 article identified as some of the things that need to go into a patient classification system. Next slide, please. So we've got a need for acuity-based systems. We've got some models out there, and I think one of the challenges for you as you think about them in terms of being implemented in your setting is how do we decide what system to use? And I would argue that there are at least 6 criteria that should be considered in assessing acuity-based systems. The first and most important is parsimony. How much time and effort is needed to implement it? And how much information is needed to get the staffing right. Workload demands, they need to be based in expert nurse judgment. Nurses understand their care better than anybody else, and to be a true reflection of nursing work. And then have indicators that will enter into that. I talked about the 3 buckets earlier, and you need to figure out ways to measure that. And then available resources, and so other organizational attributes need to be taken into account. Next slide, please. So those are the criteria for evaluating systems, and I think one of the key issues that organizations face is whether to obtain a commercial system or to develop one locally. And there are pros and cons for each of those decisions. The advantage of the commercial systems is they use an existing algorithm. They can be calibrated to the local nursing model. They do include modules that allow for direct tracking of actual versus target to understand when you're falling short, where you're falling short, what days you might have been falling short and why, and to then track those differences between actual and target and their impact on the patient processes. Some of the cons of the commercial systems is they often have high data entry burdens, although the vendors have recognized that, and increasingly they're trying to build their modules to allow them to extract much of the information about patient need from the electronic health records. And this is a moving target, so if one's considering commercial systems, one needs to sort of look at what the current state of the art is and think about how that relates to where your hospital is relative to its EHR implementation. And as I noted earlier, one of the other cons here is often turnover. Since they're focused on the patient needs, the broader issue of turnover is not taken into account. With respect to locally developed systems, some of the pros are they can be adjusted for local patient variation. It's a consensus model, so potentially we can all reach an agreement that this makes sense. Obviously, there's a data entry burden if you're growing locally and have to collect the data by hand, and no inherent linkage to tracking data entry and storage. So those are the pros and cons of each. I would encourage organizations to think about both of them. And in the next few slides, I want to talk a little bit about what locally developed systems might look like. So here's one of a local acuity model that can be implemented on paper, on a unit. Across the top, you see 4 different columns measuring acuity. And across the slide, we see some of the factors that are taken into account: complicated procedures, patient education needs, psychosocial needs, and complicated IVs and more. This comes from Harper, who developed that list that I presented earlier. You can see what happens is you figure out where your patient is, which column they're in, you get the score for that column, and then you add it up, you get a total score for the patient. And then you would take the sum of those across all the patients in the unit and relate that to a staffing model of probably average hours of care per patient for that shift, which would then translate into the number of hours of nursing needed. That's one example. There's another example on the next slide of a very different model. This is from a med-surg unit at a hospital in Washington, where they tried to develop a nurse-driven staffing demo. And they started out, they wanted the charge nurses to adjust their grid. And you can see the grid at the top, basically RNs 1 to 4 during the day, 1 to 5 during the evening and night shifts, PCAs 1 to 12 on each shift. But the charge nurses were somewhat uncomfortable just ad hocing the decision about whether or not to increase the number of nurses, the number of PCAs. So they began working through a consensus process to identify what factors would lead them to go above the grid. And you see on the bottom of this slide their judgment about when they needed more staffing. So an additional RN assigned to the unit if 2 or more of the following are met: patients in isolation, patients needing total care, feeders, blood transfusions, unusually high rates of discharge. So you see many of the factors here. What's interesting is this is a nonlinear process. It starts with the grid and then expands the staffing when workloads seem to be higher than typical. And you see similar kinds of considerations for when PCAs are assigned. And I will tell you from the evaluation of this, often additional PCA time was more valued by the RNs than the additional RN. That happens to be this hospital, this unit, where I think the staffing grid does a pretty good job of capturing typical need and acuity. But they started with the grid and were able to expand beyond it. Next slide, please. So those are examples of models. And in the last couple of minutes that I have, I just want to talk briefly about the business case issues. There are several business case or value of nursing studies that are out in the literature. Peter Bierhaus and I did one of the first that was published in Health Affairs in 2006. And basically we took some of the work we had done earlier and said, if staffing moves up from low levels to high levels, and I'll leave it for you to look at the article and see how that's defined, what happens? And length of stay goes down, so you get a large number of avoided patient days. You also get a large number of avoided adverse outcomes for patients. We were looking at change and avoided deaths. And I think the issue from a social perspective, if you value those deaths at any reasonable number, the nursing pays for itself. Next slide, please. When we actually looked at the business case, which is how much would the hospital have to pay to raise staffing, how much would it save from the reduced length of stay, how much would it save from the reduced adverse outcomes, business cases are not identical to social value. We concluded that the nurse staffing would not completely pay for itself, but it would come pretty damn close. The Increasing the number of RNs relative to LPNs definitely paid for itself. That's been shown in not only this study, but 3 others. Raising the licensed hours is a little bit more expensive, but relatively modest increase in costs in the hospitals, about 1–1.5%, depending upon how you measure it. So, other analyses are in published literature. The commercial acuity system vendors have also been doing their own analyses, which have not been published, but you ought to be inviting them in just to get their presentation of what they see as the value case for their acuity systems. I would simply note on the business case that whether hospitals can retain savings depends on the payment models. So one of the things that nursing should be pushing for is the most aggregated payment systems possible, per discharge rather than charges, capitated systems rather than per discharge systems. And the benefits to hospitals increase as more outcomes and patient-reported outcomes are included. And as we'll see a movement to value-based purchasing, we will see other outcomes which are not taken into account in the current business case models, such as the change in HCAHPS scores or the change in readmissions, tilting the value of getting the staffing right to match the acuity even more. Finally, just a few closing thoughts. Nursing is a core service of hospitals. That has to be emphasized over and over again. It's not a cost center. That safe, reliable, and effective nursing care depends on systems, on staffing at adequate levels, and the systems are available, whether they're locally developed or commercially implemented, to ensure more appropriate staffing levels match to patient acuities and needs and the way care is organized on the system. So with that, let me stop and introduce the next speaker, Sylvan Trapani, who's Vice President and Systems CNO for Premier Health.
Good afternoon, everyone, and thank you so much for the presentation so far. I'm really excited to be able to join this esteemed group of colleagues. And now that we have taken the time and hopefully you have recognized the value of the research and that we understand the why it's important to seriously consider acuity as we staff all of our respective organizations. What I'd like to do is to spend a little bit of time with you sharing with you our own experience in implementing a acuity-based system within an integrated healthcare system based in Southwest Ohio. I have the privilege to serve as the System Chief Nursing Officer for Premier Health. Premier Health is based, headquartered in Dayton, Ohio. Dayton, Ohio is roughly about 60 miles north of Cincinnati. We have hospitals that go from Middletown area, which is about halfway between Dayton and Cincinnati, and all the way up to the city of Troy. There are essentially, next slide, there are essentially 5 acute care building, if you will. It's 4 hospitals, 4 licensed building, but 5 buildings per se. We have 5 locations, as I said. We are licensed for 1,900 beds. We have 3 freestanding EDs that we currently own and operate. A little over 100 various sites of service, which includes some practices and clinics that we own across the various markets. The previous slide, please. And the other thing that I'd like to share with you, just from so that you understand who we are, we're roughly about a $1.6 billion organization with 14,000 employees, somewhere around 4,500 registered nurses in the system, and we have 1 integrated healthcare record being Epic. On the next slide, just to explain to you the reason why we felt it was important to move towards using a acuity system within our healthcare system. I could not have said it better than my colleagues prior to me, really explaining the value contribution that our service, not our cost center, but our services offer to all of those we serve. And when you think about that, and when you think about our resources are, all of you are most likely challenged, maybe even more so than we are in terms of the current turnover, vacancy, and how we're planning for the workforce, and all of the studies telling us that we're going to most likely be needing more nurses than we have today. So taking that into consideration, it is very important to address our workforce and utilize them and leverage them so that we can better establish our value contribution. And I am I'm convinced that that's the way to do that, is to take into consideration the acuity of those that we serve. Additionally, that becomes, if we don't have the data to demonstrate the hard work, if you will, but the practice and the influence that we make in the lives of those we serve, we're not going to be able to appropriately demonstrate our value contribution. And I believe that the best way to do that is to, once again, allow us to have concrete, objective data about what are the needs of those patients, what is the acuity of the patients that we have, so that we can best resource them. The other very important factor for us in terms of the case for change has to do with clinical integration. It was very, very important for us to identify a solution that was very seamless in our workflow, that would require the least amount of manual work for all of our bedside leaders, which are, to me, our clinical staff nurses caring for those we serve every day. So that was a very important thing, as well as making sure that we create some equity, that every single individual that we serve deserves to have the right resources deployed at them, if you will. And by doing that, and by doing this on a consistent basis, recognizing those needs, then you also decrease the variation on the resources, which, in my opinion, would also have an impact on decreasing variation in care, and we all know where that leads us. Next slide. We've talked about this in the prior presentation, where there are multiple ways of doing this. We opted to choose a system that allowed for full integration within our healthcare record, that allowed for full transparency. And what we mean by that is that we could leverage what's in our electronic health record as it relates to nursing documentation, and treatment, orders, placement of the patient, medication administration, all of the activities that are documented in the health record that represents what's going on with the patient, up to and including transfers, admission, and discharge. And when you take all of this together and really leverage the system and its backbone, that and the system allowing to assign an acuity to the patient, leveraging objective data, was very important for us, so that we don't ask the nurses to do that by themselves, so that it yet adds one more activity for them to do. So to that end, and of course it needed to be user-friendly, it needed to be timely, actionable data, something that we could act upon on an hourly basis as we receive, as we have access to the data. And of course, identify a good faith partner was extremely important to us. The next slide. We developed, in order to ensure that we were successful, we had to have a very strong governance around implementation of such system, very strong sponsorship from the system leadership to all of our nurses, who were very intimately involved in this process, leveraging our shared governance and leadership structure. And we also implemented using this a service line model, So number one, we can learn from one service line to the next, and we could have a much smoother transition as opposed to having the big bang approach. And for us, really leveraging the change management theories through this process and being able to identify the resistance and then the proper sponsorship was extremely important as any implementation. Next slide. I want to share with you that our future state for us is that we have just about a year's worth of data, and we're really excited that this year for us this summer starts for us our new budget cycle for 2017, and we fully intend on utilizing and leveraging all the data that we have accumulated as part of our Acuity to completely change the way that we are assigning our budgets for all of our inpatient units to begin with. And instead of using the traditional method of hours per patient day, which will be clearly a data point as a starting point, but more importantly, really utilizing the acuity that we have now and seeing what that means for our healthcare system. We have had further and further integration because of the really awesome partnership we've had with the application that we chose and that we felt was the best to meet our needs. And in fact, this application becomes really the hub of what feeds into any other application for us. So the information comes from an electronic health record. It feeds into our Acuity system, API Acuity system, and that allows us to properly assign the nurses who have, according to whatever competencies they have to certain patients, and we have a clearly picture of how the acuity looks as we add more and more patients, if you will, to that particular nurse, and then we can be equitable as we do our own assignments. Next slide. Now, it actually gives me great pleasure to introduce Dr. Carlin Kerfoot. Carlin and I have partnered in making this implementation here at Premier Health, and now I'd like to turn it over to Carlin.
Thank you very much, Sil. I think the question that we do need to address now, given all this fabulous information, where do we go from here? First of all, we have excellent content about the data that's out there, the evidence that's out there. We know from Sil about the operational opportunities, just a lot of information out there. I think we've sort of been listening to the cliff notes of acuity, a lot of information summarized in a very short period of time that should give us information for our future and direction for our future. I'm just so impressed with this content, and I'm having a really great time on this webinar. I hope everybody else is. But one of our questions is, should be, why, with so much information, we still have opinion-based staffing. We haven't been able to incorporate the data, the evidence that's out there. And why do we continue to ignore all the evidence that our speakers have presented today and continue to do opinion-based staffing versus evidence-based staffing? Well, you know what? The times are changing. And if we can go to the next slide, the times are changing, but the point is that we should be changing in addition to the times. It's difficult for us to keep staffing the way we've done 20 or 30 or 40 years ago, in spite of the fact that there's good evidence out there that we should do something different than what we've done. I'm reminded of the Bob Dylan song, "The Times They Are A-Changing." The times really are changing. And John, Jack, and Sil have given us a picture of that new world that takes data and drives it into change and drives it into outcomes. So we do have the data, we do have the evidence, we can utilize that, leverage that to get to the kind of outcomes that our speakers have been talking about. But the question is, why don't we do it? Our challenge is that it no longer is appropriate, given all this evidence, it's no longer appropriate to ignore this evidence and continue to do census-driven staffing or opinion-based staffing. The future really is acuity-driven intelligence systems, and as you listen to Sil and our speakers, there's plenty of information out there that we can turn into useful data and useful intelligence and be able to leverage those systems to get the kind of information that we need in a very specific way to make sure that our patients and our staff organizations are better taken care of. So on the next slide, we know that some people have a hard time changing, but let's look at what we actually know. Our speakers have talked to us about, the reimbursements now tied to outcomes, and clinical outcomes are tied to optimal staffing, and organizational excellence also is tied to clinical excellence and optimal staffing, and nursing excellence is tied to clinical excellence and staffing. And we've heard the data, and we've listened to how Syl has operationalized all that. So in terms of the case for change that Syl presented, this is exactly where we're at. How do we not manage our workforce, but instead how do we leverage information that we have so that we can optimize what's happening, and we can drive integration, and we can create safe outcomes for our patient and equity among our staff and engagement among our staff that we know is definitely tied to all kinds of outcomes. So on the next slide, we talk about the next generation. It really is, should be, must be acuity-based staffing. The times are changing, and it is time for us to recognize that the next generation is here because we have the data, we have the research, we have the technology, we have the systems, we can do this. So if we remember that, as our speakers have talked about, a patient is not a patient is not a patient. A nurse is not a nurse is not a nurse. A unit is not a unit is not a unit. There's tremendous variability within each of those categories, and if we don't recognize the variability and plan our care around each one of those buckets and provide the kind of resources that can match what the patient needs to the RN competencies and do it within the unit that has a healthy environment, we won't be able to get the kind of outcomes that we need so desperately to be able to improve our healthcare system. So we know that the innovation and technology is there. We know that legislation is there. We know that some of the union contracts are now beginning to consider acuity-based staffing, such as Ellis in New York has a clause in there about acuity-based staffing. And thankfully, the ANA has been developing white papers to help us facilitate raising the bar for staffing. The paper, Optimal Nurse Staffing to Improve Quality of Care and Patient Outcomes, came out on September 15th. And it's a fabulous review of what's available out there and what could be and what should be. And it really pushes that, matrices, ratios, all that is not enough. It's a much more complicated situation, and we really need more information about the nurse, the unit, the patient, and so on. No longer is it right for us to just staff against census and ignore what the patient needs are. And thankfully, the ANA convened a summit in 2014 that really drove us farther ahead in terms of this. So the times are changing. So if we think about, so what? We are listening, and we really need to do something. So if we ask the question as IHI does, what should we do by next Tuesday? Let's not wait 10 years and then look backwards and say, oh my gosh, we should have been doing something because a lot of patients had suffered in the interim, a lot of nurses had suffered, and organizations haven't been able to reach their outcomes. So on the next slide, we talk about, where do I go from here? Let's just make a commitment that we're not just going to listen to this webinar and then do nothing. Let's make a commitment that we will, in fact, support research in acuity and acuity-based staffing, the kind of evidence that John and Jack do, and that we will commit to disseminate work, such as what Syl's doing in disseminating the information through professional organization publications and so on. And certainly, support ANA and the other organizations that are really pushing to make a difference. So on the next slide, let's ask the question, what about your organization? This is a movement. This is a data-driven, evidence-driven movement to be able to do the best kind of stuff for our patients. So initially, at everybody's site, we should be supporting the move away from opinion-based staffing to acuity data-based staffing. We just should. Another important opportunity is to really champion with our teams what data-driven staffing does. Historically, many people have been suspicious of acuity-driven staffing because it has been opinion-based. But that's not the case now. So we have to do a little change management to help people understand that this is not the Acuity system of 20 years ago where people could go in and just put in their own opinion. These are data-driven systems now that really make an incredible difference. And another point is to be at the table when workforce staffing technology decisions are being considered, and to really be well informed about that, to be able to do the kinds of things that need to be done. And as Phil said, you know, we have a huge opportunity to leverage what's already there, what you already have in place with your electronic health record, with your bed systems, with all these other systems, to be able to integrate them together in a significant opportunity to really create the kind of patient care that we really need. And in the next slide, it talks about the importance of data-driven acuity staffing. I think we've gone over that very well today. I don't think anybody can argue with the fact that this really, really is important, that it does prevent bad things from happening. It really helps with nurse engagement, and it really drives much, much better nursing excellence and organizational outcomes. So the question is, why not? Why aren't we doing this? And the last slide, again, Bob Dylan said, the times, they are changing. Then you better start swimming or you'll sink like a stone. Well, we don't want our patients to be harmed and sink like a stone. We don't want our staff to be harmed. We don't want our organizations to be harmed. There's a huge pool out there of data, technology, and all kinds of information that we can, in fact, produce intelligent systems. Our speakers have talked to us about how to do that. Our challenge is to jump in right now and make sure that we can support the opportunity to do data-driven staffing scheduling, acuity-driven staffing scheduling that incorporates all the data out there, so we as an organization won't sink like a stone and be looking 10 years from out saying, why didn't we do that? Why didn't we stop at staffing 10 years ago? The times have changed, and our challenge is that we need to really move to acuity-based intelligent staffing systems and just say goodbye to opinion-based systems. Leah, Lily, you want to take over now with the
Sure.
questions?
Thank you, Carlin, so much. The times, they are changing, and our time is short, but we do have 2 questions that have come in, and I'd like to take those. And I also want to note that if you did submit a question during today's webinar that we did not have time to answer, if you'll please resend your question to Sophia Galler at American Nurse Today, we'll make sure that you get a response. But John Welton, for you, and you were talking about the need for hospitals to have different systems, really an outstanding piece around the why. We all know that there are really severe revenue constraints hitting hospitals today, and with value-based purchasing and bundled payment, do you think that these are going to affect nurse staffing and budgeting in hospitals more quickly than perhaps already? Could you talk just a little bit more about how nurse staffing and budgeting for hospitals is being affected by bundled payment and value-based purchasing models being implemented now?
Well, the simple answer is yes, in a very profound way. I mean, the payment system affects the behavior of providers, and if you're in a hospital setting, that is going to be a really big change in how we look at not only budgeting but patient care overall, because you're looking at the whole span of care, not just we replaced a hip and you're on an orthopedic unit, but the rehab, the home care, and so forth, the clinic care. One of the things that we have to think about from a nursing care standpoint is staffing is not really, it's not really the true cost of care, and many hospitals are struggling with this. They sit down and look at a particular payment, for example, open heart surgery or hip replacement orthopedic procedure, and they sit around the table and say, well, how much does nursing care cost? And we can't answer the question. So it gets back to, yes, it's related to staffing, but it's related to the care, the individual care that patient receives. So again, what I want to not plead with this, but really begin to think beyond just staffing alone, because staffing just commoditizes nursing, and begin to think about the individual nursing care and the care provided by those nurses to each patient, because that's going to be essential as far as survival skills in the future.
Terrific, thank you. And Phil, just a quick question for you.
Lily, can I
Yeah.
This is Jack Needleman. Can I just add something on that?
Please.
I think hospitals and nurses should be embracing bundled payment and value-based payment. I noted that some of the biggest savings in the business case come from reduced length of stay. If you're being paid percentage of charges, if you're being paid per diem, those savings are being pocketed by the payers. It's only when the hospital gets paid bundled, capitated, or bundled per discharge that the hospital gets to retain those. So for nursing to have a maximum impact on the quality of care and the cost of care, they ought to be embracing and encouraging value-based payment, value-based and bundled payment up and down the line, not only from the public payers but from the private payers as well.
Well said, for sure. Phil, just one quick question for you. I think you answered the question around piloting versus big bang implementation. I believe you said you did the service line implementation rather than big bang whole system. Isn't that correct?
That's correct. We found that that was a much better approach for us to look at it this way. What we did, in other words, we started with our medical surgical unit, traditional med-surg unit. Now we did all of med-surg across the system, however, and once we really understood how that was working for us, then we went on to other areas in the organization. That's how we did it, and certainly anyone who would like to have more detail about our lessons learned, I would make myself available.
Well, that's what I was going to say, because I think you obviously did a great job establishing the business case, which both John and Jack have done a terrific job articulating, and I'm sure others might want to know how you established that business case and what advice they could get from you for writing that business case for acuity-based staffing. Well, we're at the end of our time for today's webinar. If you dialed in to today's program via telephone and you weren't able to log in order to see the slides, please know that we will be rebroadcasting this webinar, and we will send details soon. And you will receive an email within 48 hours containing the webinar recording if you'd like to listen to it again. Remember, the webinar will be available on AmericanNurseToday.com for 6 months. And now, for all of us at American Nurse Today, thank you for participating. Bye-bye now.